with that, why don't we go ahead and get started? So my name is Nicholas Franco, and I help coordinate this group with Dr. Chopra here. We also have Hamza, who's a member of our team who's joining today. And I'll let Hamza briefly introduce himself and then turn it over to Dr. Chopra.
Hello, everybody. My name is Hamza. I'm a grad student in the Applied Chemical Science and Technology program at the UW. I'm really interested in the pathophysiology of chronic diseases, especially how long COVID affects diverse populations in different ways, like especially in the South Asian community, and how we can lessen healthcare disparities in those regions.
Thank you. And I'm so excited to welcome all of you to this ACP Long COVID Interest Group. I'm Anita Chopra. I am a provider at the University of Washington Long COVID Clinic, and I chair this ACP interest group. I am also co-investigator on the AHRQ grant for our clinic. This group is primarily an effort to bring you the latest on long COVID, including guidelines, research, and clinical management. And we are so honored to have experts every month to join us who give us their valuable time and their insight into this emerging condition. Today, I am so very delighted and honored to have Dr. Nikhil Kamat. He's going to talk about hematological complications of long COVID, something that's been, like an enigma, and it's uh, also very confusing and intriguing. Dr. Kamath is clinical assistant professor in the Division of Hematology and Oncology at the University of Washington School of Medicine. He specializes in gastrointestinal and genitourinary malignancies and benign hematology. He's a researcher, he's a scientist, and a teacher par excellence. Thank you so much, Dr. Kamath, for joining us.
It's great to be here. We just had a recent long COVID podcast discussion that I thought was, really excellent. And I think you've done such a great job with your leadership in, this emerging field of the sequela of infectious disease.
Thank you. And I will hand it over to Hamza. Hamza, please take it away for the first question. I think he's probably not able to unmute, but I'll go ahead and get started. So, Nikhil, can you please talk to us a little bit about the common hematological complications seen in long COVID patients, especially with a focus on microclots? That's always something which has been a sort of an enigma for me, and I have a hard time explaining to patients what it is and how it comes about.
Yeah, that's a really great question. So, I think that the manifestations of long COVID are thought to be secondary to ultimately like organ damage that happens during the actual acute phase of the illness itself. In terms of purported mechanisms of what we think is going on, there is an incredible, intense inflammatory response in the context of being critically ill that I don't think is necessarily different than the other types of inflammation that you might see in the context of critical illness secondary to an infectious disease. So, anything that gets you in the ICU, for example, anything that gets you critically in the hospital is going to leave its mark. And, one of the ways in particular that viral illness can contribute to this, at an extreme level are things like, endothelial damage that happens from either direct cytopathic effect on the endothelium or end organ damage causes things like release of tissue factor that in turn results in disseminated intravascular coagulation. If you have enough non-specific viral cytopathic effect, enough endothelial damage, enough sort of fibrin meshwork that's created as a result of all of this DIC that's happening, eventually that's going to cause shearing of red blood cells, further damage the to the blood vessels, and you have sort of a microangiopathic hemolytic picture. And all of this ends up sort of creating this cycle of damage, increased consumption of clotting factors, increased production of these fibrin meshworks that further shred up the red blood cells. Really, the only way of addressing that in the acute moment is trying to get the disease under control, which many times is successful. But then you're left rather with the sequela of whatever that disease process had on the end organ and its microvasculature. In terms of the delayed sequela, I don't see a lot of permanent hematological ramifications because just like any other critical illness, eventually removing the inciting inflammatory factor usually addresses the fundamental coagulation defect and the downstream cytopenias. But I think in terms of thinking about the etiology of long COVID, I think that, thrombosis and microvascular damage, I think at least for now, in the absence of any sort of studies that create, pathologic correlates for it, I would say that's a pretty compelling pathomechanism.
I think it's very fascinating as to what damage the inflammation itself can do, the cytokine storm. That's what I'm referring to. So I think that what you are saying is that the cytokine storm, the underlying storm, is responsible even for these thrombogenic effects. And it's not as if it's something that's ongoing. It happens acutely, but it's not something that is ongoing in the microvasculature. Is that right?
Yeah, and I would just say that, especially for very fulminant cases of COVID, on top of the cytokine storm, on top of the immune, like the inflammation, which may be in itself damaging to tissues, the virus itself, has sort of, tropism for a wide variety of tissues. If you have enough of a viremia, just like in any other sort of context of a high viral load, you are going to have tissue damage irrespective of the immune response, but the immune response can definitely amplify it.
Awesome. Thank you. Over to Hamza. Hamza, please go ahead and unmute and ask the next question.
Thank you, Dr. Chopra. So Dr. Kamat, could you just talk a little about the role of inflammation and immune dysregulation, the formation of microclots and microthrombi?
Yeah, just going back to the prior answer, I think there's multiple mechanisms. One thing is that any sort of damage to tissue in itself is going to release tissue factor, which is, factor 7, one of the elements of the clotting cascade that can in turn lead to the formation of thrombi. And if you have enough endothelial damage, enough tissue damage, enough sort of thrombosis that's happening inappropriately, eventually you create these sort of fibrin meshworks. So, fibrin is ultimately one of the foundations for developing a clot. And if you have enough of it sort of in circulation as a result of cumulative damage, you will eventually also create a phenomenon where platelets and blood are also getting shredded and further damaging tissue that in turn releases more of this tissue factor and creates more clotting. So it's essentially sort of a situation that is amplified by the immune system, in that the immune system has an interest in trying to target cells that are infected. And if a cell is targeted by the immune system for being destroyed, or if the inflammation drawn by all of these events creates more immune infiltration, that non-specifically can also damage tissue and further release these substances that catalyze the formation of clotting. So from my perspective, I think it's really a combination of, in severe cases, things like DIC, and, at an extreme level of DIC, a microangiopathic hemolytic process that can cause this damage that is amplified by the immune system. The challenge, though, is for how do we explain subclinical COVID, right? COVID that doesn't lead to a hospitalization, COVID that doesn't lead to an ICU visit. Can we say that that is the mechanism that's also responsible for any long COVID in those patients? I think the jury's out on that. I don't think we have enough clinical correlates. We don't really understand long COVID in that context to really make a claim on that front.
Can I just make a comment? This is Grace
Sure.
Hassid. I'm from San Mateo Medical Center, a small but essential hospital. We take care of the people who are underinsured. And basically, I had read many years ago now from another researcher who talked about uh, basically at the very smallest level of the single red blood cell, and that level of the endothelium and the microvasculature, that basically COVID causes almost like a wall which the red blood cell hits and then ruptures, and you have clotting basically from that, and this is very, very early in research. So this is so fascinating to me, Nick, to hear you go into greater detail about what's happening with the fibro mesh, components, because I could never, he said, that researcher had said other infectious diseases and other issues of insult to the microvasculature results in not a kind of fibrin mesh wall situation, but more, it can actually stimulate growth, almost to go around, or for the body's response to this catastrophe happening. It actually engenders growth, but whereas COVID doesn't do that. It's like there's it's the red blood cell kind of hits a wall. And again, I'm speaking as a non-researcher. I'm a clinical person, not behind any kind of electron microscope. So I thank you, but this is fascinating. And it gives, I'm just saying that I've heard this same concept, a long time ago when research just started. So thank you for elucidating further.
For sure. And, I think that, when we think about like long COVID, I think one critical thing is, we have to, think about kind of what is our comparator arm, because anytime I think about sort of the sequela of like, a devastating sort of systemic illness, we have to think about it in like, what are some other things? So for example, other like a severe enough viral infection that is going to get you into the ICU can cause a microangiopathic hemolytic anemia. The same process, the same pathophysiology is at play. Other things that are at the even more extreme of that, for example, enter the STEC, right? The Shiga toxin E. coli, or anything that makes Shiga toxin. Shiga toxin essentially causes direct damage to the endothelial cells. It has a tropism for whatever reason to the endothelial cells. And again, creates this same phenomenon, probably at the most extreme level. So I think that part of why I think COVID can do this, or has, I think, been associated with this, is partly it's a numbers game. When you have enough people are going to be severely ill, and you're going to see viremia, impressive viremia, and impressive sort of presentations that are going to lead to this. But I think an important thing to note is that any severe viral illness that gets you hospitalized, I think can really have an impact like this. And we should be mindful of it, in hopefully we don't see many, but pandemics to come.
Thank you.
Thank
And I'm sorry, I didn't mean to interrupt, and I won't ask any more questions. Thank you.
No problem. I did just want to chime in and say, Will, feel free to put questions in the chat, and we will also have a Q&A at the end as well. So no worries. I did want to switch gears just a little bit here and talk about maybe some risk factors and what might make individuals more susceptible to these sorts of complications, aside from just the kind of usuals from acute illness, or sorry, severe illness in general.
That's a great question. From my vantage point, just reflecting on some of the like, nascent long COVID literature, this field is not, something that, I mean, COVID itself is so new, right? So the literature is going to, be, I would say, limited. But I think one thing that it is a recurrent phenomenon is that less fulminant presentations are less likely to lead to this. Earlier intervention and viremia seems to have an impact. For example, there are studies showing that, earlier initiation of things like Paxlovid has a tangible impact on the manifestation of long COVID, and of course, vaccination, right? Um, this to me suggests that, going back to that pathophysiology of the viremia and the viral induced inflammation leading to this downstream damage, which with the potential microvascular component, it seems that if you hit the fundamental originating cause, the virus, I think that that can have a major impact. And so I'm a big advocate for reducing your risk factor fundamentally with vaccination. And in those who, despite vaccinated, get infected, I think it's reasonable to consider treatment for the virus, even in situations where it might be more of a subclinical presentation. That's kind of, I would say, one of the biggest risk factors. Beyond that, I think that anything that increases your risk of susceptibility for getting the virus is something that we have to consider. So profound immunosuppression. I work with lots of patients who, due to either chemotherapy or, the sequela of the things that they've undergone, like transplant or CAR T, are in an unusual position of being even more susceptible. This kind of brings up a topic that I think is worthy of additional consideration, and that is what's the optimum duration for this medicine in the specifically Paxlovid, but you could apply to any of the anti-COVID agents in those who have rebound. Because we've all encountered situations where the patient has a phenomenal response and then they rebound and they start having more symptoms. I've been in tricky situations where someone who's profoundly immunosuppressed, where I feel compelled to give a longer course, to address the symptoms. Because otherwise, for me, it's not necessarily from the long COVID angle, although it's worthy of thinking about as a research question, but it's purely to make them feel better and to avoid the potential of a hospitalization. But I think that is a question that we should try to answer as a research community. Does giving an extended course of Paxlovid for those who have rebound impact the possibility of developing long COVID?
And we actually
That
did
is
have one, sorry, Dr. Chopra, we had one quick question in the Q&A about an extra dose help more than the normal dose. I assume that's in reference to an extended dose, which you were just referencing, but
Yeah, I think extended dose, because I think the way that the medicine works is that, the ritonavir itself is supposed to increase the concentration and the persistence of the nirmatrelvir. So I think that the pharmacology of it is, you're trying to use one drug to increase and augment the presence of the other drug. I think it's an unanswered question. I think clinically, I think, I'm more, especially for very immunocompromised people who don't have cell-mediated immunity, who are very symptomatic, I'm more inclined to consider the possibility of extended course, but we just don't know.
This is actually very interesting that you're talking about extended course of Paxlovid, and there are trials going on about it as well. I know people from Yale are looking at it. Um, some initial studies have, reported hit or miss benefit from it, but they have been on a smaller scale. So, Nikhil, we have talked about microclots. We hear a lot about microclots. Patients bring up, the fact that, hey, I may have microclots. We know that in the acute phase, patients who are seriously ill can have PEs. They can have, thrombogenic states. But as far as these microvascular clots, do they cause peripheral vascular disease, or do you see organ damage from them, especially in patients who were very severely sick with acute COVID-19?
That's a great question. So, I will say the caveat of this is that, typically when I'm consulted on a patient in the hospital, it's typically for some alternative derangement or cancer. And so my snapshot is going to be a little bit altered in terms of just like, the population that I'm looking at. Again, I always think about sort of what is my comparator arm. So, for example, there are certain conditions that create clots or thrombotic phenomena within the microvasculature, which have very typical overt imaging or lab evidence. So on the extreme end, right, as a comparator, you're thinking about things like TTP, thrombotic thrombocytopenic purpura, which is not infection related. And then, of course, microangiopathic hemolytic anemia secondary to an infection, specifically something like STEC, right? So those you will see very commonly, imaging evidence like on an MRI brain. Hey, you are seeing some evidence of macroscopic damage as a result of this microscopic process, and it's pretty unequivocal when you see that phenomenon. And then typically on renal ultrasound, sometimes you're seeing damage when someone's creatinine is at 5 and it's being damaged by this. You can sometimes see something in the subacute phase. I would say that with COVID, I don't necessarily see that. That doesn't mean that it's not happening, but I think it's a distinct picture. I think that it is something that I have limited experience with, because usually when I'm seeing someone in the context of COVID who's critically ill, most often I'm consulted really about, cytopenias, because many times having an extreme viremia is going to create some sort of, cytopenia that is more often the times why I'm seeing them. But to directly answer your question, I see an imaging correlate of damage less frequently outside of the lungs um, for COVID, like less often CNS manifestations in terms of imaging correlates. Definitely within the lungs, that's probably where it's most fulminant and most visually apparent.
Okay, thank you. Go ahead, Nick, with the next question.
So switching gears a little bit again, it seems, we talk about endothelial dysfunction, and are there any specific diagnostic tests that you know of or would recommend for these patients?
Not specifically with respect to endothelial damage, because, endothelium is everywhere, and so I think that if you're going to see a dysfunction of it, it has to ultimately manifest in some of the labs that you're drawing. If you're really thinking about the possibility of a coagulopathy, or a microangiopathic process, with respect to coagulopathy, the great tests for DIC are ultimately going to be the PT, PTT, fibrinogen. If you're having something that's truly massively consumptive, you will see some abnormalities on that front. simultaneously, if you're thinking about something that is really consuming red blood cells and platelets, you're going to see that on a CBC, and it's the downstream sequela are ultimately going to manifest as some form of end organ damage where the endothelium is present, right? So, creatinine change, liver enzyme change, troponin, these are the markers that I think are more relevant rather than anything specific for endothelium, which is so ubiquitously present.
I was going to ask you about the markers for endothelial dysfunction, but you answered that. So maybe now is a good time, Nikhil, to talk about treatment for microclots. What are some of the treatment options available? And there's a question also from in the Q&A from Malini as to what treatment options are available for microclots for these patients.
That's a great question. I would say that, the use of anticoagulation in the setting of DIC, I think is a little bit controversial and I don't think has a consensus. But in terms of thinking about prevention, I think that, uh, not so much the treatment of microclots, but the prevention of sort of macrovascular thrombosis and mortality. I think there is some literature about that, and there are some guidelines. So, I would say two guidelines and two organizations that I follow very closely with respect to thinking about thrombosis are ASH, American Society of Hematology, and sort of the International Society of Thrombosis and Hemostasis. And they do have guidelines in the context of COVID-19, but they're a little paradoxical. They're not what you would think. So, I would say both guidelines, from my knowledge at least, coalesce around the idea that critically ill patients benefit less from therapeutic dosing of anticoagulation compared to acutely ill. That seems surprising, right? You would think that the more critically ill you are, the more of an impact the anticoagulation may have with respect to preventing these sequelae. But actually, the randomized control trial evidence, and the meta-analyses suggest that there may be a benefit from a thrombosis and mortality perspective for those who are ill enough to go into the hospital, but not ill enough to be in the ICU. It may be a benefit to therapeutically anticoagulate them if there are no contraindications with respect to bleeding, compared to those who are critically ill in the ICU, where it's just prophylactic anticoagulation that's recommended. The reasoning behind this is kind of unclear. Like, why do we see this happen? It could be that someone who's so critically ill with COVID, it may be that their mortality is already so impacted just by virtue of being in the ICU that the anticoagulation is not really, in the grand scheme of things, going to matter compared to all the other stuff that's happening to them. I think it's unclear why that's the case, but definitely the current ASH guidelines are structured that way, that those who are acutely ill consider therapeutic dosing of anticoagulation, and if not, then at least prophylactic, but for critically ill, just do prophylactic because there's no benefit necessarily seen from therapeutic dosing, and sometimes it can do more harm than good, potentially from a bleeding perspective.
Great, thanks. I wanted to ask about autoimmune hematological conditions after long COVID. Do you see many of these pop up in long COVID patients? And do you have any kind of tips for diagnosing and managing them?
Great question. I just want to contrast this to kind of the phenomenon of acute COVID. Acutely in COVID, depending on the severity of the presentation, you can see all manner of cytopenias. I had talked about sort of cytopenias associated with like fulminant presentations, like thrombosis, and MAHA, microangiopathic hemolytic anemia. But outside of that, you can see sort of um, direct suppression of the bone marrow. So I've seen, for example, like in the absence of any sort of thrombotic process, sort of pancytopenia as a result of, ostensibly because of the virus. And I would say I've seen neutropenia, again, ostensibly secondary to the inflammatory milieu of the virus. We don't know. We kind of wave our hands. We never know what the true inciting factor is. More commonly, I would say most commonly, in terms of delayed sequela, I see ITP, so immune thrombocytopenia. I would say that for example, in patients who have had immune thrombocytopenia who have been very well controlled for a long time, um, they, develop COVID and it sets off their ITP as any sort of infection can. I would say that in those patients, I see sometimes patients who had initially responded just to steroids and then did not have any need for a secondary agent like Rituxan or Eltrombopag. I've seen those patients then suddenly get COVID, and then I need to, you know, they're not steroid responsive as much as before, and I need to jump to a secondary agent. So these are things that I see anecdotally, but I don't necessarily have, the literature evidence to, point to a more increased prevalence of it.
So, Nikhil, to your point, I have had patients who had ITP and their, platelets have continued to run low, not, markedly low, but continue to run on the lower side while they are recovering from COVID, but also into their long COVID phase. What about other cell lines? What about blood dyscrasias or suppression of other cell lines, especially the impact on bone marrow? Do you see all that with your patients, especially who have some sort of blood disorders like maybe thalassemia or ITP? Do you see any of that?
Not as a long-term phenomenon if they have not suffered major end organ damage. Like, for example, in those patients who have issues with like kidney disease, for example, there is the kidneys are intertwined with respect to the bone marrow, the hematological system, partly through erythropoietin, which is a hormone that, helps support the hemoglobin and hematocrit. So I would say through conventional mechanisms for those who have been very ill with respect to COVID, if it does impact their renal function long term, I do see impacts on anemia. But otherwise, for those who have fully recovered, I typically do not see any major prolonged cytopenias.
That is very helpful to know. And I think there is a question in the chat. Any suppression of antibodies or hypogammaglobulinemias? Do you see that?
Typically not. If anything, if someone has like, I would say like recurrent bouts of COVID, and as long as their immune system is functioning, typically I see, sort of robust, persistent immune responses. When you test their spike antibody, it typically, is quite elevated. So I personally have not seen hypogammaglobulinemia. For those who have chronic liver injury or chronic liver disease, and if, it's exacerbated by COVID, hypergammaglobulinemia is typically seen in the context of chronic liver disease of all kinds. But otherwise, I typically don't see the opposite phenomena.
I think I will open it up now for any questions. If folks have questions, please feel free to unmute and ask.
We do have one here from the chat. Would you consider people with autoimmune diseases who are not on immunosuppressants still high risk due to their autoimmunity?
Um, for um, for for COVID or long COVID?
I think they're saying in the context of in the context of COVID and autoimmune diseases and the potential to develop new autoimmune diseases in those who already have them.
That's a really good question. I think that it's really hard to say. I would say that it depends really in the context of the autoimmune disease. I would say that it's such a wide spectrum of disease to kind of make a blanket statement about that. Certainly, I would say my kind of domain for autoimmune disease typically is more within the hematological perspective. So like, things that I have seen personally, outside of ITP that set things off, are things like, TTP. TTP very commonly, can be set off by a viral trigger, even if the TTP has been in remission for a long time. So, I would extend that to say that, I would say the principle should apply to other contexts, but as a general principle, I would say we're data deficient.
Thanks. And I think if folks have questions, feel free to use the raise hand function and we can go ahead and ask.
Grace has a comment. Are you aware of research regarding creation of microtubules generated by the virus to aid transport of the virus from nasopharyngeal mucosa, where it enters to go directly to the brain due to neurotropism? I haven't heard of this. I don't know if Nikhil has, but I am not aware of this.
I think it's intriguing, and I think, I am also not aware of this mechanism of sort of COVID infection in the brain, but I think, it highlights something that I think we are sorely lacking in terms of understanding the pathophysiology of this disease, and that is actual sort of, like tissue correlates for how the disease is manifesting in different parts of the body. Like I think that for someone who has long COVID, we don't know actually like what the tissue looks like, that of someone who like, what does the brain of a long COVID patient look like? Like we have other disease entities that affect the brain where we know that, like, for example, like all of these, NFL players or boxing people, like chronic traumatic encephalopathy has like a definite sort of pathophysiologic histological correlate. And I think that, although I don't know the answer to this question or I'm not aware of this research, I think it highlights the need for this type of better understanding of what is the histology of this, because I think it will help us understand the pathology a little bit better. The challenge is that, most of the histological studies, I think, are going to come from those who are, who've died, right? It's going to be biased towards those that have a fulminant presentation, right? And so in that sense, I think that there still is a paucity of data that I think will come to light, as people, patients who are brave enough to, either donate their, bodies eventually for science, are analyzed. I think that that may be something that might be sort of an interesting way of further interrogating this among other questions about long COVID.
And also, the development of some biomarkers, which will be very helpful in diagnosis, especially of, conditions like even chronic fatigue, even like brain fog. So I think that's also very important to develop, biomarkers through really robust research.
Totally.
Any other questions? And I see Grace has a comment, but no other questions. This has been truly a very insightful and informative session. Nikhil, thank you very much for this discussion. And I learned a lot. And I think that you cleared a lot of the confusions that I had, and especially around the microclots and endothelial damage. And thank you for this opportunity to learn from you. We appreciate you explaining things in detail, and I hope that all of us, everyone in the audience feels the same. And this session will be recorded, and Nick will put this up on our web page as well. Nick, do you want to tell folks about that? And also, please highlight our next session, which is going to be, we are very honored to welcome the director of HHS, Dr. Ian Simon, who will be joining us next month for this webinar as well. So go ahead, Nick.
Sure, and there will be more information to come on that, but it will be March 26th, and we will be sending information out. I think the other thing I just wanted to highlight is that it is currently in the works to get CME approved. That's a question that a lot of folks have asked, and I am happy to report that in the coming months we will likely be able to give CME. So look out for that as well. We will make an announcement when we send out our flyers for the next meetings. So we are on YouTube. That's where these are uploaded to. So look out for those links, or you can search ACP Long COVID on YouTube and find these talks. With that, unless there's anything else, I think we'll thank Dr. Kamat and close it out.
Thank you very much, Nikhil, for your time. We appreciate it, and we hope to bring you back with more questions.
Outstanding. It was really great being here. It was an honor. Thank you for inviting me.
Thank you so much to everyone who could join today, and thank you, Grace, especially.
Thank you, Anita. So kind. Thank you for including me.
Bye.
Take care. Bye.
Bye.